and they are really far behind. It's very difficult actually when countries don't have the resources to pay for these expensive medications. We have this amazing NHS that we can do that, but we also have very brilliant doctors, both in primary and secondary care. So today, Hanif and I thought that a good topic to discuss would be a talk that I'd done earlier this year, and it was actually based on a trial or a paper, a systematic review and a meta-analysis of randomized controlled trials in the BMJ about the benefits and harms of drug treatments. So what does all this systematic review and meta-analysis and of randomized controlled trials mean? Whenever new medications come out, it's really important that they're safe. There's no point having a medication that's really good for diabetes if it's going to give you cancer or going to give you other side effects. So it's really important that we have medications that are safe. But what we found over the last 5-6 years is that we've now got new medications that are actually better than what we already have. And so they're called superior. So medications, they're studied in what we call randomized controlled trials, which means that you randomly give some patients the medication and some people you don't. And it's random because, you don't want to pre-select people who are more likely to say, yes, I've got the placebo effect. And you study these new medications in randomized controlled trials and you see do they have benefit or not? And then you put all of these different randomized controlled trials together because people are studying all these medications all over the world, some England, some America, some Australia, some in Japan. Put them all together and you pool the data, and that's called a meta-analysis. And to do a review, a systematic review, means systematically looking at all this data to see, actually, do these medications, are they beneficial? And how much harm do they cost, and how much harm do they produce? And so this is what this talk is about today, and it's going to be very informal. If you guys have any questions, please go ahead and ask. These are all my disclosures. I do speak for various drug companies and so on, but this talk should be free of bias. I am a GP, as many of you know. I also am a lead in the ICB, which is the OCCG. I'm also a teacher at the medical school. So those are all my that's what all those letters after my name mean. Okay, next slide, please, Harif. So are we having difficulty moving to the next slide? Hanif, any luck in moving? Perfect. Okay, just the one before. So this article was based on 816 randomized controlled trials. That's a lot of trials. And they looked at nearly 500,000 patients, and we looked at 13 different types of diabetes treatments. You probably didn't even realize that there were so many different types of treatments, but they are. So the next slide. So the next slide tells you all the different treatments that were actually involved. So let's just go through them. And so that way you know what medications you're on. Just the one before that, please. So SGLT2 inhibitors, that is dapagliflozin, empagliflozin, and canagliflozin. Some of you know these medications as Jardiance. So they are the brand new kids on the block. Then we've got the GLP-1 receptor agonist. Those are those injections that you take once a week that can help you lose weight. Dulaglutide, semaglutide, liraglutide. Okay, then we've got these new medications called finerenone. You may not have heard of that right now, but that is something new that's coming up. It's good for people who have kidney disease. So kidney disease is now becoming really important. You probably don't realize that you may have chronic kidney disease, so speak to your doctor about that. Tirzepatide is a brand new medication. It's actually the best for weight loss. It's a combination of a GIP and a GLP. Again, I don't expect you to know about it, but I just want you to know that this has now been approved by NICE. Metformin, we all know about metformin. Alpha glucosidase inhibitors, acrobose. It's a very old medication. Some people might still be on it. Thiazolidinons is pioglitazone. Some people might be on pioglitazone. Then the DP4 inhibitors, linagliptin, alogliptin, you may be on that. SU's very old, gliclazide, glimepiride, you might be on one of those. Miglatanide, it's actually very, very old. Don't expect many of you to be on it. But then the other interventions are basal insulin. So that is the insulin that you take just once a day, but perhaps at night, Toujeo, Tresiba, Basaglar, and so on. Basal bolus insulin, which means that you take a basal, one at night, one or in the morning, all day, and then a bolus for whenever you eat. And then bolus insulin. So these were all the interventions that were studied. This was all the different types of diabetes treatments we have in the world, and we pulled them together and we decided what is the benefit of these treatments and which ones cause harm. So I thought this would be quite a good thing for us to just review your medications, tell you about side effects, tell you about the benefits, and tell you why you're taking some of these medications. Okay, next slide, please. So we looked at these medications and we thought, well, what is it that we're looking at? What are the outcomes? So whenever you get a new medication, you think, what? So just a slide before that, please. So what are the outcomes we look at? We want to, so ultimately, the reason we treat diabetes is to reduce your risk of heart disease. Of course, one of the first outcomes is all-cause death. We don't want people to die. So we want to make sure that if you start these medications, are people dying from it or not? So all-cause death should be reduced in all of these medications. Cardiovascular death should be reduced or at least not increased. Non-fatal heart attack, non-fatal stroke, admission for heart failure, kidney disease, and severe hypoglycemia. So all these things were studied. So if you're taking these medications, the first thing we want to make sure is that it's safe, that it doesn't increase the risk of death. And now we found that some of these medications reduce your risk of having a heart attack, reduce your chance of having a stroke, heart failure, and so on. Okay, so the next table, next slide. So this is actually just a synopsis of the major medications. So what I'm going to do is a very busy slide, but I'm going to actually go through the medications, and I think this is probably the best slide that we're going to go through. So first of all, SGLT2 inhibitors. So that is empagliflozin, dapagliflozin, canagliflozin. It was found that if you give that compared to just standard therapy, standard diabetes therapy, all-cause mortality went down. That means that if you take this medication, your risk of dying goes down. CVS death, your risk of dying from stroke or heart attack goes down. Your risk of having a heart attack goes down. So you see, these SGLT2 inhibitors, some of them people do have side effects from them. They have urine infections and they have thrush and so on. And if you look at the adverse side effects on the very last column, those are the side effects of these medications. Some people don't want to take them, but have a look at what else it helps. It helps reduce your risk of having a stroke. It reduces your risk of having heart failure, and it reduces your risk of having kidney disease. So these medications are so important. It's not just about treating your diabetes. It's about reducing your risk of dying. It's reducing your risk of having a heart attack. It's reducing your risk of having a stroke, reducing your risk of having heart failure, and also reducing your risk of kidney disease. Okay, so severe hypos, very few. Okay, so that's that class of medication. The other class of medication I want to talk about are the new GLP-1 analogs, the injections that you take once a week. Again, reduces your risk of death, reduces your risk of having a heart attack or stroke, reduces your risk of having a non-fatal stroke and a non-fatal heart attack. Heart failure reduces your risk of having heart failure, and it reduces risk of kidney disease. So you can see these two new classes of medications, actually, they're not just good for diabetes, they're good for your heart, they're good at reducing your risk of having a stroke, they're good for reducing your risk of having kidney disease, and they do have side effects, and their main side effects are that they have nausea, vomiting, and some people can't tolerate them for that reason. I'm not going to go through finerenone and tirzepatide because they're not available yet. But let's have a quick look at metformin. So metformin also reduces your risk of having dying. Now, does it reduce your risk of having a heart attack? Not really. Dying from a heart attack. Does it reduce your risk of having a heart attack? Possibly. So the different colors imply the strength of evidence. So we don't have very good evidence with metformin, but overall, we know that if you take metformin, actually look at under admission for heart failure, 40 more admissions for heart failure. So you might take metformin, it might reduce your risk of dying, all-cause mortality, not necessarily dying from a heart attack, but it doesn't actually help with heart failure, and it actually causes more people to have kidney problems. So you can see that these new medications are actually better than metformin. Metformins are tried and trusted medication that we use all the time. And then just to look at SUs, the glycosides and the glimepirides, if you look at all-cause mortality, actually you take glycoside, your risk of dying goes up. So there's lots of people who shouldn't even be on this medication. Again, if you look at heart disease and stroke, it's not very good. And the big thing is causes hypoglycemia. So I'm going to stop there because those are really all the medications I want to go through, because I want to tell you about the benefits and the harms of these medications. There's lots of other medications, and I'm going to open the floor up for questions, but that's what I wanted to bring up to you. Can I just check what the next slide is, Hanif, please? So this is just a summary slide. We're not going to talk about finerenone and tirzepatide, but SGLT2s and GLP-1 receptor analogs, those are the dapagliflozin in the injections, they all reduce your risk of dying, all-cause mortality, and they reduce your risk of dying from heart attacks and stroke, and they reduce your risk of even just having a heart attack. Okay, the injections reduce your risk of having a stroke, and the SGLT2 inhibitors reduce your risk of having heart failure and kidney disease. So you can see today it's a bit of an academic talk, but I wanted to introduce you to the idea that actually these medications have more benefits than just helping diabetes. They help your heart, they help your kidneys, they help you for reducing your risk of having a stroke. And it's really important that you take these medications. Some of them do have side effects, but try and take them. Next slide. Was that the last one?
Yes.
Okay, perfect. Okay, so I'm going to open it up now. Is there any questions? I know there was quite a complicated talk, but at least I gave you an idea of the concept that actually these diabetes medications are beneficial for lots of things: heart, your kidney, preventing a stroke, and reducing your risk of death.
Thank you, Hina, for that presentation. We have been submitted a few questions, and already participants have raised some questions. We'll just go to the questions that have been submitted first. We've got a question from Janice, and he says, can your pancreas start working again if you've got type 2 diabetes?
Well, unfortunately not. If the pancreas has been damaged, with time, your pancreas gets worse and worse. Unfortunately, it cannot. It's an irreversible damage.
Okay, great. Got a question. I think we'll just quickly go to the floor. It's got Kirti on. Kirti wants to ask a question, and then Cam wants to ask a question. Kirti, if you want to unmute yourself, and then we'll come back to the questions that have been submitted.
Yeah. Hello, Dr. Trivedi. I take metformin, 2 metformin in the morning, 2 in the evening, and then I've been aided with another one as well for diabetes. So basically, I'm just getting the name of the other one. Basically, how do I get the doctor to change my medication?
Yes. So what I want you to do is find out what your other medication is, but depending on what your control is like, if your control is not very good, you should say to them, could you please put me on an SGLT2 inhibitor? Now, I know Dinesh is also asking, what's the alternative to metformin? Well, no, if you can tolerate metformin, you must take metformin because it does reduce your risk of having from dying.
Okay, so the other medicine
if you can't tolerate metformin because it's very sick, you feel sick, you can go on sustained release, the long acting. If you can't sustain that, then you should go on an SGLT2 inhibitor.
SG2 inhibitor.
If you could write that down for me, Hanif, SGLT2 inhibitor.
And the one I've been given extra is for Forxiga.
Forxiga. So that's dapagliflozin. You already are on SGLT2 inhibitor, so that's great.
Yeah, 10 milligram. The other thing was, just quickly, I saw you at the temple at Nishi's prayers, and
Yes.
I was quite surprised. I recognized you straight away as you came. You gave a very good speech. You know.
Thank you. Yeah, that was very, 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 very unfortunate. It was his funeral.
Yeah. The thing is, I went with him 3 times recently because it's my niece's Masi's son, and she invited the whole family. So I sat next to him at Indigo. It was sad, but it was nice to know him. Put it that way.
Thank you, Katie. The question from Can. Can, if you want to unmute yourself and ask the.
Okay. Thank you very much. Thank you, Doctor. I just almost same question I wanted to ask anyway. But as she said, can we go and ask the doctor? Sometimes, because you are a GP anyway, you are all terribly busy. You wouldn't have gone through all the patient's record anyway. So is it possible for us to go to the GP and ask, this is the thing I'm taking now?
Yeah.
Can I switch to? That can be done.
You might not need to switch to it, but they might need to add it. So you can say to them that, look, I went to this talk. This is Dr. Heenan. Most people know me in the city anyway. If they have a question, they can ring me up anyway or email me. But just ask them, could I please be on this medication? Yeah. Should I be on this medication? And they can discuss it with you.
Yeah. Only thing, you are saying even we can keep on. I'm actually taking 2 in the morning, 2 in the afternoon metformin. In addition to take that, I can still last for.
It depends where your control is. If your control is very good, you may not need anything else.
Right.
Now, if somebody's asking, is it okay to take metformin and Ozempic? Yes, it is. Ozempic is a GLP-1 analog, so yes, it is. So just going back to your question, Gan, is that it depends what else you have. I mean, I don't know if you've had, hopefully you've not had a heart attack or stroke or something, and what your risk factor is for having that, or whether you have problems with your kidneys. Because if you do, then you actually should be on these medications. So ask your doctor, should I be on this medication?
Yeah, okay. Thank you very much.
Thank you, Cam. We've got a question from Dinesh. Dinesh, if you want to unmute yourself and ask a question to Dr.
Hi, Dr. Ina. What I wanted to know was, I'm on dapagliflozin and metformin.
Okay, that's SGLT2 inhibitor, dapagliflozin.
Yeah. Are they good, both of them?
Yes, very good. So remember, SGLT2. So the SGLT2s was on that very first row. Okay.
Yeah.
Ozempic. Somebody asked a question. I think Dinesh Bhai. Oh, it might be you. To ask about Ozempic, which was the GLP-1 analog. So remember the very first 2 classes of medications. So good. Forxiga, dapagliflozin is in that first row.
To let you know, for your interest, I went in this diabetic in Leicester General for a trial. They're the ones who recommended it, dapagliflozin.
Good.
Metformin. So when you say metformin is a little bit iffy, what's the alternative?
Metformin is not iffy. Metformin reduces all-cause mortality. It reduces your risk of death, but it was found that it can affect your kidneys. So we all know that if you have kidney problems, we'd reduce the dose of metformin.
Oh, okay. I've lost about a lot of weight, so I am more or less on the borderline.
Good. Is that because you take Ozempic?
Yeah, I think so, yeah.
Yeah. So Ozempic is semaglutide, which is a GLP-1 analog, and it's very...
Dapagliflozin, sorry.
Oh, dapagliflozin. Okay, not Ozempic. So dapagliflozin also you can lose weight, and that's really good.
Well, I lost something like 20 kilos,
which
is very good. Exercise and everything else.
That's good. Well done.
Thank you, Dinesh.
All right. Thank you very much. Thank you for your...
We've got another Dinesh. Dinesh, if you want to ask your question.
Hi. Yeah, it's Dinesh. I'm normally working in Birmingham, live in Leicester, so I'm in Birmingham at the moment. But my question is, I've been on metformin 2 in the morning, 2 in the evening, mostly over 10 years now. My diabetic reading is always, for the past few months, 48, 49. It's come down from 52, and I worked hard to reduce it. Now, looking at the chart, should I be going on the second one, which was mentioned on there, which had low risk factor? My other medications are candesartan 2.5 milligram and amlodipine 2.5 milligram. But my main concern at looking at the chart was, should I be going on a different diabetic tablet? The second one, I think, everything was lower on there.
Yeah, no, so 48 is pretty good. It's actually, right around hemoglobin A1C of about 6.5 or so. So actually, that's a good level. So depending on what else you have, whether you've had heart attack, stroke, whether you have a high risk, you don't necessarily need to go on any new medications.
Yeah, I haven't got any other risk. Cholesterol is always 3.5, hovering around there. I don't take any statin or anything because it gives me muscle. Yeah. But the thing is, my kidney EGFR is always above 90.
Okay, that's very good. So then you don't really need anything else. Yeah, I think metformin is doing the trick, so that's great.
Okay, so I don't need to change anything. Okay, that's fine.
Great, thank you, Dinesh, for that. Quick questions, Dr. Hina, from people who have submitted questions. We've got a question from Manju. She's asking, what should one's blood sugar be first thing in the morning? Mine is usually between 5.0 and 6.9.
That's perfect. That is perfect, Manjubin. That is perfect. That's exactly where you need to be.
Brilliant. A question from Shobna. She's asking, why does my GP insist I go on insulin?
Well, it depends what your hemoglobin A1C is. If your hemoglobin A1C is around 9 or 10, you're going to need insulin. Do you know what your hemoglobin A1C is? She may or may not be here. Okay, the thing is that if you have a high hemoglobin A1C, that means that your pancreas has stopped working. We talked about the pancreas damage being irreversible. Once the pancreas stops working, pancreas produces insulin. If it stops working, then you're going to need insulin.
Great, thank you. We've got a question from Salim, and he's asking, why is every new diabetic patient prescribed metformin?
Because that's the oldest, safest medication we have, and it's our gold standard.
Great. We're going to quickly go back to participants. Sukhvinder, if you want to unmute yourself and ask a question to Dr. Hina.
Hi, Dr. Hina. It's Sukhvinder here. I had a COVID jab in June. I'm diabetic and obviously have a rheumatoid arthritis. And I taken in June. And now they're asking me, keep getting it. I should get another COVID jab. Do you think it's too soon, or I should take it?
How many have you had in total?
That was probably the 4th or 5th.
Yeah. The thing is that because you're at high risk, that's why you're getting these reminders. Some people aren't even eligible. It's a difficult one, isn't it? People are still getting COVID. People are still, unfortunately, getting ill from COVID. I think the official recommendation now is that, look, if you are at high risk and you're offered the medication, the vaccine, I would just probably take it unless you got side effects from it. The immunity lasts at least 3 months. So if you had it in June, then you may as well get it again. It'll help you over the Christmas time.
I'm going to India for 3 months, so I don't know.
Definitely get it then.
All right then. Thank you very much.
And that way you're protected in India.
Yeah. Thank you.
Okay, I think Dinesh Bhai had a question. You want to unmute yourself?
Sorry, I forgot to ask one more thing. With all those nice readings, 48, 49, everything, I take 2 metformin in the morning, 2 in the evening. Should I tell my doctor to reduce it to 1?
No, I think just stay on where you are. You're well controlled because you take those medications.
Okay, that's fine. Thank you.
How are we doing? Had a long question answer session today, Hanif. Hopefully everyone's got their questions answered today.
Can I
question answer always works really well. Yeah, sure.
I am on Sucrato tablet once a day. Is there any?
Sucrato is metformin. It's the same as metformin.
Is it? Is it the same?
Yeah.
All right, because I had reversed it, but recently I got my blood sugar at 7, so
Okay.
I've been advised to start take again.
You should take that, and you should go on an SGLT2 inhibitor.
What's it called?
So I think Hanif's going to write it in the chat. Ask your doctor.
Yeah.
Who's your doctor?
It's Dr. Harrop at Greengate Medical Center.
Okay, I don't know them, but ask them to put you on an SGLT2 inhibitor.
Oh, right. Okay. I'll have to write that name now down, you know.
Yeah.
SGL
T2 SGLT2 inhibitor.
Okay, thank you.
It's like SGLT2, and they'll know what that is.
Can I ask a question quickly, Dr. Hina?
Of course, sure.
All right. Okay. Right. Now, my sugar levels, the last 3 years, slowly going up. From 6, it went to, I did a lot of intermittent fasting and fasting. 6, then it went to 6.2, and now, a few months ago, 6.5. Now, of course, I went on just one metformin because I wasn't eating till 1 o'clock anyway. And so there was no time for the second tablet. So they put me on 1. So I'm taking 1 a day. Now, because it's going up, creeping up, my son-in-law was saying I should be taking another 1. Or do you think I should take the long-release metformin? Should I ask my doctor for that? What do you think?
Either way. I mean, if you can just take, if you don't have to take the long release, just take the short acting. You can take 2 tablets, twice a day. You don't have to take it 3 times a day.
Right,
either is fine. Either is fine.
2 in one go after my sort of lunch, and then that should carry on. Because it's going up. It's going up. I mean, it's not going down. Right.
Yeah,
all right.
Definitely.
Thank you very much. Thank you.
Okay. We have Natuba and Shardaban, is it?
Yeah. In August, I went to Specsavers for eye check, and they said I had got diabetic macular edema.
Okay.
And he referred me to the Leicester Royal Infirmary.
Sure. Yeah.
And then since then, I've seen the doctor, and I've been prescribed metformin 3 times a day. Obviously, I do not wish to, the edema. I wish to at least keep it stable, or control it.
Of course.
Anyway, I can do it.
So what should you do? You should control your diabetes, you should control your blood pressure, but you must go for regular eye checks, because now if you have macular edema, I don't know if you've got macular degeneration or if you've got maculopathy. If you've got a disease of the macula, your central vision will reduce. So they might have given you those ESLA charts with the wavy lines and asked you that if anything changes, go and see them. So one thing you can do is, you could go to Specsavers and get an OCT, pay the £10, and you could get a scan done, and that will have a look and see whether you've got macular edema or not. So obviously, if you go to eye casualty, they'll do a scan for you and decide whether you've got how much macular edema you have. The thing is you can get injections for macular degeneration, depending on I'm not exactly sure what you have, but depending on what you have, they'll get the treatment for you. But it's really important you control your diabetes.
Yeah. Okay.
Are we all done now, Hanif? I think this question and answer session always works out really well, doesn't it?
Absolutely. Hina, you're so popular, that's why. We've got some quick questions on the chat, which is, what time is the best to take metformin? Because I have breakfast at noon, some snacks in the afternoon.
Take it when you're actually going to take it, okay? It's better that you take it than not take it. So, I mean, if you're 3 times a day, then take it morning, lunchtime, and evening. If you're going to do intermittent fasting, then just take 2 at lunchtime and 1 in the evening. So it doesn't matter. What the most important thing is you take your medication. 70% of patients don't take their medications the way we prescribe them. So I'd rather you take the medication than not take the medication.
Great. One is if it's okay to take Ozempic if you have been diagnosed with liver.
Yes, it is. I think we need to look at that, but yes, I think it is. In fact, there's something called fatty liver disease, which one day we may talk about, but these medications are helpful for fatty liver disease.
And is it okay to take metformin and Ozempic together?
So it depends on how abnormal your liver functions are, but yes.
Someone asking again, what is the alternative to metformin?
So you should take metformin if you can take it. If you can tolerate it, you must take it. But if not, somebody's asking, you only have one kidney, is metformin safe? Yes, it is. Just it's important to check your kidney function all the time. Metformin is only if you have really bad kidney, like if your EGFR, if you know what your kidney function is, the estimated glomerular filtration rate, if it starts dropping below 50 and 45 and 30, we need to start thinking about reducing your metformin dose. It is safe, but we need to reduce the dose. As an alternative to metformin, if you really can't take it, try the long-acting release. And if you can't take that, then you can go on any of these medications. You could go on DPP-4, which is alogliptin, linagliptin. You could go on SGLT2, and so on.
Thank you, Hina. That was an amazing presentation. So many questions put in answered. Thanks a lot.
Okay.
Very good subject you chose.